Ma'am, start பண்ணலாம் மேம்.
Ah, good evening, everybody.
நான் இன்ட்ரடியூஸ் பண்ணிடுறேன் மேடம்.
Yeah, okay.
Sure. Good evening, all. Please welcome to the 25th edition of our TMC Monologues. Today, it is my privilege to introduce Dr. Sujatha Jagadeesh, ma'am, a highly accomplished clinician and academician in the field of clinical genetics. She is the head of the Department of Clinical Genetics at Mediscan Systems, Chennai, where she has led the department for over 26 years. She is a consultant geneticist and dysmorphologist with extensive experience in the diagnosis and management of complex genetic disorders. Her contributions extend significantly into education and capacity building, having been deeply involved, having been deeply involved in teaching and training fetal medicine students. She has also demonstrated commitment to patient care by establishing a comprehensive one-point care center for rare diseases, including lysosomal storage disorders, spinal muscular atrophy, inborn errors of metabolism, and Down syndrome at the Center for Rare Diseases, ADAR, where she serves as the director. She also has a very important role in national initiatives and the coordinator for the Birth Defects Registry of India under the Fetal Care Research Foundation. She is also the current vice president of the Indian Society for Inborn Errors of Metabolism. In addition to her clinical and academic work, she has authored book chapters, published in index journals and international journals, and delivered numerous presentations and conferences. So it is our honor to have her to deliver the 25th talk of the TMC Medalogs, and I hope this session will be useful for all alike, both PGs, undergraduates, as well as experts and those who are interested in genetics. A recording of this talk will be uploaded as soon as it is done. So I welcome Dr. Sujatha Jagadeesh, madam, to deliver her talk for the day. Thank you so much for doing this for us, madam.
Thank you, sir. Thank you for your kind words of introduction and to all my dear friends, teachers, and colleagues. So, today it is a very basic talk on how to take history in a genetic scenario setting and how to draw a family pedigree. So, this will be the core subject of the talk today. So, genetic disorders affect humans anytime from fetal life to adult life. And also, there is a vast heterogeneity in presentation because they can present as structural defects or a functional abnormality or biochemical defects. So, that's the complexity of picking up a genetic diagnosis. So, first of all, let us understand when all we should think that a problem could be genetic in etiology. In a fetal life, if the screening test is positive, if there is a fetal anomaly, if there is an unexplained growth restriction, or there are multiple minor anomalies in an ongoing pregnancy. These are the situations in the fetus where we think could it be genetic. And in the immediate family, if the previous child has developmental delay or structural problem in any system, or parent has a problem, or a person has multiple problems, or if the marriage is consanguineous. So these are the situations where we think that the problem could be a genetic problem. And also in extended family, so different birth defects in the family, that's how the pedigree chart comes handy. So when there are different birth defects in the family, and also issues like deafness, night blindness, muscular dystrophy, short stature, structural defects, or even cancers in the family, so these are the situations where we think could it be genetic. And in reproductive issues, if there is a recurrent pregnancy loss or infertility, so we think could it be genetic. So these are the situations where our antenna should be high up and looking for genetic etiology. So a detailed history and pedigree will help us to decide if it is genetic or not. So history taking in genetics, there are three terms which one should understand, and the genetic books will be mentioning these terms. So consultant is a person who has approached us for knowing the genetic risk. Historian is the person who gives the family details, and proband or index person, he or she is the person with a genetic problem in the family. For example, Mr. A has come for consultation, so he becomes the consultant, and his wife's brother has a genetic problem, so he becomes the proband or the index child or the index person. And the mother-in-law has come to give history about this person, so her son, so that is the historian. So appointment fixing, the because it is a process where the couple have to come together. There is no point in the husband alone coming or wife alone coming. That doesn't work. And couple should come, and we insist on that. And they should bring all the records. And if there is a child or a person with a genetic problem or a developmental issue, that person also should be physically present in the clinic. And we start the discussion informally, introducing ourselves. We ask them what are their concerns and explain about why they have been referred here, and find out who all have come for the consultation, who are the other family members, and explain to them what will we be doing by taking a detailed history prior to a genetic consultation. So the importance of why we need to take a history has to be explained in the first place. Otherwise, they get a little jittery, and they may get a little scared also why they are asking all these questions. So we have to first explain to them the need. And also preparation, as I told you, the couple have to be present for the session, and the family member who is giving information on behalf of the couple, we have to get the couple's consent whether other family members can be there in the counseling room. So if they give the consent, then they can be allowed. Or if the couple wants a private conversation, I think we have to respect that. And privacy is very, very important, and phone should be off hook. And explain that we need information about all the family members' health, and we will be collecting information about 3 generation members, and accurate information is very, very essential, and this information is going to help us in genetic diagnosis and also predicting risk to the family. So we have to first of all understand the mindset of the family, because the persons sitting before us will be filled with anxiety and guilt because they have either a reproductive loss or a previous child with a problem. They don't want to hear anything negative most of the times, and they sometimes may not want to divulge information, or they may be doing a blame game between themselves, and there will be a lot of fear and lot of frustration. So our first duty is to establish a rapport and gain their confidence, because again, the accurate and detailed history is the cornerstone for accurate genetic diagnosis. So in history taking, we have a structured case sheet where we have the name of the couple or the child, age, date of birth is very, very important, blood group, qualification, contact number and address for later communications, what is the occupation, what is the place of origin, and what is the ethnicity. And I will take you through different case scenarios as to how the history taking will differ, and I will illustrate with case example. For example, this is a situation where there is a pregnancy, ongoing pregnancy, and the fetus has an abnormality. So, how do we proceed with history taking? So, first of all, we need to go through a detailed maternal history. What is the method of conception? It is natural or IVF? What was the method? What is the paternal age? What is the maternal age? Blood group? And did the mother have any medical illness or surgeries? And history of drug intake, whether in mother is on any drugs, whether she is having the habit of taking alcohol or smoking, and also about the previous pregnancy details. What was the mode of delivery, outcome? So everything has to be recorded in detail and documented. And also history pertaining to the system involved. For example, if I am confronted with a fetus with a cardiac anomaly, I need to check on the parental cardiac status, and also I look into the family history whether somebody has had a heart murmur, a heart surgery, or a heart attack or high BP. So we have to ask probing questions so that to get out the information from the couple. And because they may not remember everything at one shot, so keep on asking and then they recollect and then come out with more information. If the fetus has a skeletal problem, we need to look at the parental height, and we need to ask the family for history of fractures, bony deformities, the curved spine, short stature, unusual shape of the limbs or hands and feet, any issue with joint mobility. So like this, we have to ask leading questions to find out if there is any related problem in the family members. And if the fetus has a renal problem, we immediately have to check the parental renal status and the family history of dialysis, any surgery, any ultrasound of the abdomen has been taken for somebody. For this is the first case of to illustrate if the fetus is presenting with an anomaly. So here you see this is a cardiac image of a fetus, and you see there is a rhabdomyoma. This is a cardiac tumor. So this is a couple, non-consanguineous couple, and they have come for a target scan, which is done usually at the 5th month. So rhabdomyoma usually is associated with the condition called tuberous sclerosis. So we need to immediately examine the parents. And when I examine the parents, the father was absolutely normal. The mother, as you can see, has adenoma sebaceum, and she had periungual fibroma, and she had this ash leaf macules, and her CT showed there are tumors in the brain. So, and she gives history of seizure. So this is the confirmation of the diagnosis that it is tuberous sclerosis. And when we did the genetic mutation for the mother, we found that she had a mutation in the TSC2 gene. So well, now the etiology is identified and we know it is autosomal dominant and there is 50% recurrence risk in every pregnancy. So history will, that is the mother giving the history of seizures and sort of a developmental delay and issues. Then we probe into other questions and then we get into these information. So this is a fetus who had a flat facial profile, had epiphyseal stippling, and had platyspondyle and kyphosis. So this is a classical presentation of a condition called chondrodysplasia punctata. And usually chondrodysplasia punctata is genetic. But as usual, when we were eliciting the history, the mother's history, I found that she had symptoms which are characteristic of SLE. So then when we did the tests for SLE, then the things were positive, ANA was positive, and U1-RNP is a very strong marker which can present as chondrodysplasia punctata in the fetus. So proper history taking was done and we diagnosed SLE in the mother. So there are two advantages in doing a proper history taking. We diagnosed the maternal condition and we avoided expensive genetic testing in the fetus because it is not genetic and it is because of the SLE in the mother. Now, if there is a previous child which is affected, then we go into the history, obstetric history, general obstetric history is elicited. And for this child, what was the mode of conception? Was there any teratogen exposure? And we go through all the ultrasound and screening reports and what was the delivery details. And then the examination findings of this particular baby. What was the anthropometry, head circumference, length at birth, and what was the neonatal course? How was the feeding? What were the developmental milestones? Were there any medical concerns? And what was the time of identification of the problem? What were the tests done? And we need to go through all the investigations very meticulously and also understand the clinical course and the treatment given so far. So this amount of exhaustive history taking is very, very essential. And also we should review the older photographs or videos. For example, this man's wife had come for a pregnancy scan and that baby had abnormally bent long bones, the fetus. So when this man didn't come for the consultation, and so the wife said that the father also had some limb deformities. So then I had to go through the photographs. This was when he was a baby, and then when he was a adolescent, he started developing fractures. So as a baby, there were no fractures, and during adolescence, there were onset of fractures, and during adult life the fractures were more and he is not able to walk now. So this was the course in the father. And this man's father also had fractures which happened when he was 40 and above. So now this fetus has fractures in the womb. So this is a classical autosomal dominant presentation where there is variable expression and variable age of onset. So this is osteogenesis imperfecta. So we review the older photographs for a better understanding. And we can take photographs also, or we can document these photographs and videos with an informed consent. So this informed consent is very, very important. So I will illustrate this concept with a case. So this is a third degree consanguineous couple. In the first pregnancy, antenatal period was normal. The maternal, there was no drug intake, infection or illness. And she delivered by cesarean section because of non-progression of labor. But birth cry was normal and neonatal period was absolutely normal. There was no jaundice, no infection, and all the milestones were normal. The child started babbling. And by around 1.5 years, the child started losing acquired motor milestones. So this history elicitation is very, very important. Child which was normal and attained milestones started losing it and slowly could not recognize parents, started having seizures, drooling, frequent aspirations, succumbed at 5 years. But the child was diagnosed as cerebral palsy and no major investigations were done. The second child also had a similar course and both children were male children. And this second child was currently bedridden when the child visited me and no major tests were done. And when I looked at the family, the maternal aunt married consanguineously, lost two children with a similar, almost a similar history. But then there was a boy a baby and a girl baby. So when I reviewed the photograph, because the first child was not alive when this family came to me, but the older photographs, when I saw this child, and both the children were looking very sprightly, and this is the current status of this second child. So a well child has regressed. So this cannot be cerebral palsy or birth asphyxia, because cerebral palsy is usually not recurrent and it is a static insult, and then there will be slowly improvement and the child never deteriorates like this. And consanguinity and disease link could be there. Here, both children are males, so we have to keep that in mind. And the second child was later completely evaluated. MRI showed white matter hyperintensity. And when I did the tandem mass spectrometry, there was elevated very long chain fatty acids. And molecular testing proved that it was an X-linked adrenoleukodystrophy. And mother was confirmed to be a carrier. So now we know that this family has an X-linked recessive problem, but the maternal aunt kids has some other problem because there was a boy and a girl affected. So we need to completely reevaluate that family. So this is how the information is helpful to the family by doing a thorough investigation and history taking. However, this couple, because they are consanguineous, they also require carrier screening because they are consanguineous. So, though they have a diagnosis of X-linked adrenoleukodystrophy, because they are consanguineous, they may also carry other genes which are responsible for autosomal recessive disorders. So now a couple has come to me with the recurrent child loss. So the mother has lost her previous 4 pregnancies, and in the 5th pregnancy at 16 weeks, it was a natural conception. First trimester screening was normal. Then she developed polyhydramnios, and usually when there is polyhydramnios, usually we test the maternal blood sugar, and it was normal. And when we did the USG, in addition to polyhydramnios, the fetus has talipes. And when we went into the previous ultrasound findings, all babies had polyhydramnios and talipes, but no other structural abnormality. And because of the polyhydramnios, they expelled prematurely, and no autopsy or genetic test was done, and no fetal sample was stored. So, just the presence of polyhydramnios and talipes, because of our previous experience, we know that there is an association of this condition with myotonic dystrophy in the mother. So I went through the history, and then the pedigree and family history was unremarkable. And mother gave history of fatigue and muscle pain, which was increasing over the years. And she frequently dropped things, and she had difficulty in operating doorknobs. And she had undergone cataract surgery when she was in her teens. And on looking at her, the face was very thin and hands look a bit wasted. And when I elicited the myotonic reflex, it was positive. And EMG then proved it was myotonic dystrophy. And then the triplet PCR is the test required to diagnose myotonic dystrophy, showed more repeats than normally we expect. And so, unless we go through the history and the clinical examination and ordering the right test, we will not end up in diagnosing this myotonic dystrophy. Whole exome sequencing or microarray will not reveal the diagnosis of myotonic dystrophy. So proper stepwise examination and elicitation of the history helped us to arrive at the diagnosis. So if you see, the first was a boy, and then there were 2 girls and then a boy. And this present pregnancy, we did a prenatal testing and we told her that the fetus is affected, but mother was in a denial and she was continuing the pregnancy. And that is the autonomy we give to the parents, because if they wish to continue, they continue. And now this is the other case where it is a non-consanguineous couple recently married. The wife's maternal uncle was said to have Down syndrome. So they were referred to rule out Down syndrome in this pregnancy. That was the referral reason. So a pedigree were drawn. Her mother's parents were consanguineous. She did not know the details and no medical records were brought. So we asked for a family photo where we could see the maternal uncle. And when I looked at the photo, the maternal uncle never had any features of Down syndrome. So we refixed the appointment. Her mother, maternal grandmother, and uncle all were asked to come to the clinic because we need to collect information. And when we went through the history, he was born to, this is the maternal uncle, and he was born to non-consanguineous parents, and he had global developmental delay. His cognition was low, and he needs supervision and self-help tasks. His CT brain was done, and it was normal. When I examined him, he was dysmorphic, poor cognition, systems were normal, no neurological findings. So I did, because of dysmorphism, I did a karyotype and I found an unbalanced translocation between 2 and 9. And when his parental karyotype was done, the mother was a carrier of a balanced translocation. So our patient's mother, this is our patient who came for consultation. This is her mother. And because if only she is a carrier of a balanced translocation, this girl has problem. So when we did the mother's karyotype, she was absolutely normal. So there is no problem for this girl at all. So just by word of mouth, if somebody says Down syndrome, we should not believe. We should take a proper history and examine the index case. And a couple presenting for routine ultrasound. So this couple were from West Bengal. There were no risk factors. They came for routine scan. Because of their ethnic origin, we did a CBC for the couple and we found that the hemoglobin was low and the hemoglobin electrophoresis proved that both of them were thalassemia trait. So, and we did the mutation and they found to be carriers. And so we opted, they opted for a prenatal testing and we found that the fetus was affected with thalassemia major. So they didn't come for any complaints, but just because they come from West Bengal, all these investigations were triggered. So history of where they are coming is also quite important. So advanced maternal age poses risk for chromosomal aneuploidy. Advanced paternal age poses a risk for autosomal dominant conditions. That's why documentation of age is very important. And similarly, ethnicity is different for various disorders. And also in India, in Delhi, there is a condition in Agarwal's community where there is the condition is called megalencephaly, where there can be cognitive decline, progressive spasticity, ataxia, and white matter changes with temporal cysts. So different ethnic groups in India have different conditions and even across the world. So that's why documentation of place of origin is very important. So, and also germline mutation, most of the cancers are because of somatic mutations, spontaneous somatic mutations, but sometimes cancers can happen because of germline mutation. So when the family history, there is a lot of members with the different types of cancers, we definitely have to rule out germline mutations. So this is a twin brother and the second twin two had married non-consanguineously and he had come for consultation. At 12 years, he had seizures and he was on anticonvulsants and seizure free till date. But when we did his MRI, right cerebellar and vermeil cystic astrocytoma was there and there was a recurrence and he has been operated 5 times for cyst in the brain. And then they have done a whole body MRI. There is hemangioblastoma in the brain. Spinal cord is normal, adrenals normal, kidneys normal. And in the pancreas, there were numerous pancreatic cysts and he's married for the past 11 years, one live child, and now this is the second pregnancy. And when we elicited the history, the other twin brother also had symptoms of vision problem and retinal tumor at 26 years. And he was found to have tumors in the retina, brain, spinal cord, kidney, and few in the pancreas. So this presentation, hemangioblastoma in the brain and all these tumors gave a suspicion of von Hippel-Lindau syndrome. And when we did a mutation analysis, we found that there was a mutation, heterozygous pathogenic mutation in the VHL gene. And the father wanted a prenatal diagnosis because he didn't want his child to suffer. And we did a prenatal diagnosis and the child was unaffected. So this is an autosomal dominant condition with 50% recurrence risk. So when there are cancers in the family, also think about genetic mutations. And this couple with an anomaly in the ongoing pregnancy, non-consanguineous couple, came for target scan and we found that the fetus had hypoplasia of both the femora and severe micronathia. And when I went through the obstetric history, the first was a spontaneous abortion, second was a term intrauterine demise, and the parental KT was done in between these two pregnancies. It was normal. And the third pregnancy ended up with the lumbosacral meningomyelocele and terminated. So this is the fourth pregnancy. So any clues? So this could be because of uncontrolled maternal diabetes. So just a simple sugar test we did and the random sugar was 343 and HbA1c was 12. So this could be the answer for all her obstetric problems. So the abortion, the IUD, the neural tube defect and the present problem are all because of diabetes. And there is no need to do any extensive genetic investigations. So eliciting maternal history is very important and we should not be diagnosing diabetes following a fetal anomaly. So that is very, very important. Maternal diabetes can cause diabetic embryopathy It can cause congenital anomalies like all types of neural tube defects, caudal regression, cardiac anomalies like TGA, proximal femoral hypoplasia, and renal anomalies, ear anomalies. So it causes a multi-system embryopathy. So good control of diabetes is very, very important. And similarly, maternal infections, varicella can cause limb contractures and skin hypoplasia. Congenital rubella can cause microcephaly, cataract, heart problems. And congenital CMV syndrome can cause sensory neural hearing loss, microcephaly, chorioretinitis. So maternal infections also can mimic genetic conditions. And also maternal illness. For example, if the mother has a PKU, the child can have microcephaly, cardiac defects, and dysmorphism. If mother has SLE, the child can have congenital heart block, eye drops, neonatal lupus. And as we saw, maternal myotonic dystrophy, that baby can have talipes and polyhydramnios and a very stormy neonatal course. And similarly, various drug exposures like retinoic acid, anti-epileptic drugs, warfarin can cause different types of birth defects. So not all abnormalities are because of genetic reasons. So all this history elicitation is very, very important. So this is a fourth degree consanguineous couple lost two children with global developmental delay and seizures. And because of this presentation, suspicion was for inborn errors of metabolism, and tandem mass was normal, and urine organic acid analysis revealed a problem. But children are not there to confirm. So what we did, we retrieved the filter paper because they had done the tandem mass spectrometry on a filter paper. So we retrieved the filter paper and extracted DNA from it. And then we confirmed the mutation, that there was a pathogenic mutation in the HTRA2 gene. And it confirmed the diagnosis of 3-methyl glutaconic aciduria. And we tested the parents for the same mutation and we found them to be carriers. So if the child is diseased, we can ask for a filter paper or an umbilical cord in the diet which they keep, or if there is any stored blood or frozen urine sample, all that has to be asked and we can use that for confirming the diagnosis. So similarly, infertility. So when there is infertility also, we think of genetic reasons. So it could be because of female factor, it could be because of male factors. So we do a 3-generation pedigree and we ask for all this information. And this is a case where there was a non-consanguineous couple married for 2.5 years. And because of infertility, they came for a genetic workup. And husband was found to have azoospermia. And when I saw the scrotum ultrasound report, he had congenital absence of vas deferens. So this congenital absence of vas deferens can be there because of a mutation in the cystic fibrosis gene. So we need to look at the sequencing of the cystic fibrosis gene, and we found that he had a homozygous mutation in the cystic fibrosis gene. And we tested the wife, she was not a carrier, and the sperm was retrieved and an IVF done, and they have a normal child because he only has a homozygous mutation and the wife is normal. So all his children will be carriers, but nobody will get the disease. So history taking is very important, and reviewing all medical records, examining family members, reviewing old photographs, documenting all findings and getting details specific to the anomaly are very vital. Now we move on to how to draw a pedigree. Pedigree is just a pictorial representation of a complicated 3-generation family history. At one glance, we can see the concerned person in question and what are the risks to other family members. So it helps as a tool to explain families their genetic risk, and patterns of inheritance is very clearly evident when we draw a pedigree. But then it has to be updated at every visit because new information can be added on. So this is useful for educating the couple and to explore their understanding. But there are etiquettes to be followed because it is like digging out skeleton from a closet. Many may not want to keep, many may want to keep the information private. So we have to choose words appropriately. Instead of saying positive or negative family history, we have to say whether the family history is contributory or non-contributory. So using the talking, the language used during pedigree elicitation is very, very important. And we have had different experiences, and over the years, we have learned the languages to be used during history elicitation. And instead of asking, are your sisters, brothers healthy? You should ask whether there are any health problems. And don't use medical jargon when you're eliciting the pedigree. And be sensitive to cultural issues. And do not rely on a single family member for information because facts may be changed from person to person. And these are the symbols. Any standard textbook will give you these symbols. These symbols only have to be used in pedigree drawing. So this square is a male, this is a female, and this means the sex is not defined like in a fetus. And if we shade, we know it is affected. And more than one pattern, if we draw, that means more than one problem is there. And this is the number of children, that is 5 male children, 5 female, or 5 fetuses. Or if we don't know the number, we put the n inside. And then if a line which is slashed across means that person is not no more alive. And this is for the shaded and the proband. And not shaded and narrow means it is the consultant. If it is an abortion, we just put a triangle. And if the fetus was affected and aborted, then we shade it. So like that, there are different symbols. So here, double line is for consanguinity. And then for twins also, we put a line like this and connect it if it is monozygotic. We don't connect it if it is dizygotic. And if they are infertile, they don't have children, then we put one line. And if there is adoption, we square and then don't connect it to this parental line. So that is how different symbols are there to draw a pedigree. So to start the pedigree, this is a pedigree chart which we use. I have printed this pedigree chart so that it is easy to start drawing, and the pedigree looks a little neat. And there are online tools where we can draw pedigrees online also. And we start the pedigree in the middle of the page. Male partners are to the left and females to the right. And the siblings are drawn from the left to right. That is, the oldest will be on the left and the youngest will be on the right. And we use different shadings if there are more than one problem, as I told you earlier. And we have to include age and date of birth of each individual, date of death, and what are the medical problems, and ethnicity wherever required, key shading of symbols, adoption status, consanguinity, and then when we are the date on which we are drawing the pedigree, and all the medical conditions which we are going to elicit in that family, we have to indicate. So this is the husband and wife, and then the vertical line from the parents, it is called the line of descent. So this will mean this will connect you to the line of sibship. So this is called the sibship line. So this father and mother has a son, has a daughter, has another son, and an abortion. So like this. So this is the latest, and this is the first. So from left to right, it will proceed like this. And then we add on the sibs of the parents, the uncles and aunts. So the mother's siblings and the father's siblings. And then we add their children. So adding the cousins. And then we add the grandparents. So the father's mother, the mother's mother on either side is added. So and then you write the name, who has taken the pedigree, date and signature. And then when you update, also you write the updated information on which date you are updating that information. So the genes which are shared in identical twin, there is 100% sharing. Between a parent and child is 50%. And a full sibling, it is 50%. So these are all first degree consanguineous. And then grandparent, grandchild, 21st, uncle, aunt, uncle, niece, aunt, nephew, and all, they are 25%. So they become second degree consanguineous. First cousin sharing is 12.5. They become third degree consanguineous. So when you draw a pedigree, you can know from who are all the affected members, the pattern of inheritance. So in autosomal dominant pedigree, you see that males and females are affected, and every affected person transmits the disease to the next generation. So this is classical autosomal dominant. In autosomal recessive, this is called a vertical transmission. And here this is called horizontal transmission because in 3 generations, there is no persons who are affected. And consanguinity is more prone for getting autosomal recessive disorders. And suddenly the problem appears in 1 generation. Here also males and females are affected. And in X-linked, you see that only the females are carriers and males never transmit the disorder. And in mitochondrial, only the affected mothers will transmit, the affected fathers don't transmit the disorder. So there will be a little similarity to dominant, but when you closely look, only the mothers transmit and the fathers don't transmit in mitochondria. So looking at the pedigree, we know what sort of inheritance it is. So by drawing a pedigree, we definitely get some clues. I'll just illustrate a few case examples before I close. So this is a third degree consanguineous couple referred for counseling in view of echogenic kidneys at 22 weeks. And ultrasound also mentioned that the fetus has some polydactyly. So when we did the pedigree, they are third degree consanguineous. We mentioned the degree of consanguinity on the line. So this is third degree means we put 3. And here we see that this cousin, who is also third degree consanguineous and has a child, mental retardation, polydactyly, and night blindness. So this child has echogenic kidneys and polydactyly. So we asked that child to come to the clinic. And when we saw the child has obesity, has retinal problems, and polydactyly. So both could be a similar condition. And the diagnosis was Bardet-Biedl syndrome. So we stored that fetal DNA and we confirmed the mutation in this child. And we found that both babies have a similar problem. And this couple, they came at 20 weeks of pregnancy, non-consanguineous couple. The mother has been having recurrent hydrocephalus in the last 4 pregnancies. Husband has some psychiatric disorder and some tremors. So this is the pedigree, and they are non-consanguineous. Non-consanguineous means single line. Consanguineous is double line, like how you see here. And all these pregnancies were terminated because of hydrocephalus. This boy died, but these were terminated. And this is the pregnancy with the problem, current problem. And the mother's brother also died because of some hydrocephalus. That's what they say. And when we went through the history, the first child died on day 3 of life. And we examined the photos of the first child. The child had adducted thumbs, which is the most significant finding. And subsequent pregnancies terminated, no autopsy was done, and all were male children. And patient's sibling had macrocephaly, maybe hydrocephalus, which we don't know, global developmental delay, and said to be infection. Probably they didn't investigate that boy properly. So we thought all male members are being affected, so it could be X-linked problem. So this is a classical condition where there is hydrocephalus and adducted thumb. So L1CAM is the gene which causes mutation, and when we did the mutation, we found that this fetus had hemizygous mutation, which is pathogenic, and the mother was found to be a carrier also. So looking at the pedigree, we can predict the mode of inheritance. So similarly, a couple came for counseling because the brother had hyperactivity and developmental delay. And this is the couple who came for counseling. They are non-consanguineous. They had one abortion and one female child, and they were planning for another pregnancy. But because this brother of this man had some behavioral problems, they came to me. And when I examined, I found that features were suggestive of Fragile X syndrome. And when I drew the pedigree, I found that so many other individuals also had similar problems in the family. And the whole family, all these members were affected with Fragile X when we tested. And all these mothers were carriers of the problem. So one leads to the other. But fortunately for this husband, because he is normal, for this family who came for counseling actually has no risk. And then we also get the extended family gets benefited by the investigations done for a couple. For example, this couple came to us for recurrent abortions. And when we did the usual investigation is doing a karyotype. And when you did a karyotype, we found that the mother had a balanced translocation between 9 and 13. And so that is the reason for her abortion. So we gave her reproductive options in the subsequent pregnancy, whether we can do a PND or a pre-implantation testing, or she can go for a donor gamete. So when we gave those options, and when we elicited the history, we found that she has 3 more sisters. And when we did karyotype, we found one of the sister also had a balanced translocation. She's unmarried. So we can ask her to take precautions when she gets married and goes to take on a pregnancy. So the extended family can also get benefited by the couple's investigation. Similarly, the couple can also get benefited from an extended family information. This is a third degree consanguineous couple. Their first child had hypospadias. So they came to me for investigation of the hypospadias, and they had terminated 2 other pregnancies for fear of the hypospadias being recurring again. So when I examined the child, apart from hypospadias, there was nothing. And all the basic investigations were normal. Child was doing well and growing well, and all milestones were normal. And concerning hypospadias, there was karyotype was normal, adrenal metabolism pathway was normal. So there was nothing of concern for this child. But when I drew the pedigree, I found that these two were brothers, own brothers, and they have married the uncle's daughters. So two different uncle's daughters they have married, but these two are own brothers, and they are also third degree consanguineous. So they had lost a child with citrullinemia, which is a urea cycle defect. So both of them are coming in the same family line. And so this mutation was checked in the parents, and I found to my surprise that both were carriers. And so we tested the fetus, the current pregnancy, and was found to be affected with citrullinemia. So they came for counseling for hypospadias, but because of the family history, they were tested for citrullinemia, and the ongoing pregnancy was affected with citrullinemia. So benefit from the extended family also comes to this couple by drawing a proper pedigree. So to summarize, good history taking is an art, but we have to have a lot of patience and empathy and equal care for eliciting details in both the dead and live babies, because the baby has succumbed. We cannot ignore all the facts. We have to dig in, like how we elicit a history in a live baby. And information to be communicated to the family. Three generation is a useful tool in understanding inheritance pattern. And also we can have an idea about the comorbid conditions in the family. And we can confirm inheritance, plan tests, arrive at a proper diagnosis. We can warn at-risk members and reassure members with low risk. So thank you all, and any questions I'm happy to take.
Thank you so much, ma'am. It was very lucid and, as usual, very clear, and all the points were kind of, drives home the message very clearly. So now the
Thank
floor
you.
is open for questions to Dr. Sujatha, madam. So those of you who want to ask a question, either raise your hand or you can unmute yourself and ask the question.
So pedigree, you can start drawing with your own family. So you can practice pedigree by drawing with their own family members. So I think whenever there is a suspicion of a genetic problem, drawing a pedigree is a very useful
Absolutely.
exercise. Yeah.
Yes, ma'am. Thank you so much, ma'am. I think there are
Thank
no
you.
further
Yeah.
questions to people.
Okay.
So I think thanks for giving us another wonderful talk in genetics, especially
Thank you.
being the 25th edition of the TMC Medalogs. This is a very special occasion. I certainly
Thank you
would.
so much.
The problem is that a lot of conferences are happening. World Congress of Nephrology is
Yeah.
happening in Tokyo, and so many other things are there. So I think most of the usual seniors are not available today. But nevertheless, I think they would certainly enjoy the video which I'll be
Yeah.
posting shortly. Thank you
Thank
so
you so
much,
much,
madam.
sir.
Thank you.
Thank you, sir.
Thank
Yeah.
you all of you for participating. Take care.